So today we will talk about cecum. So cecum is the beginning of the large intestine. It is a blind pouch. This is a blind pouch. This is cecum, and this is the blind pouch. It is blind from below. It's blind, not all around. It is blind from the below. So it is blind on the its inferior aspect or the lower end, and at the beginning of the large intestine. And this is the beginning of the large intestine. Feet. It's where it is located. It is located in the right iliac fossa. This is the right side, and this is the left side. So this is located in the right iliac fossa. It is located above. This is the iliacus muscle, and this is the psoas muscle. So it is located above the iliopsoas muscle. It is located in the right iliac fossa, and it is located just above the inguinal ligament. It is located just above the inguinal ligament. So this is the inguinal ligament. So it is located above the inguinal ligament in the right iliac fossa, just above the iliopsoas muscle. Now it has got three communications. One, it is communicated superiorly with the ascending colon. It is communicated superiorly with the ascending colon. Communicates medially with the ileum, which is from the ileocecal junction, and posteromedially it communicates with the appendix. Its lengthwise, it is 6 centimeter length. Its length, this length is 6 centimeter. What is width? Talking about its width is 7 centimeter, 7.5 centimeter. So its width is more than the length. Its width is 7.5, length is 6 centimeters. So width is more than the length, and it is dilated pendular sac, look like an ampulla. So it is an intraperitoneal organ. So it must have the peritoneum, and we will see its peritoneum and the peritoneal fold and the retrosical with the peritoneal recess also in our next slide. So it is a mobile organ. Why it is mobile? Because it is being enveloped by the peritoneum. So any abdominal organ which is being enveloped by the peritoneum is the mobile one, and one which is not enveloped by the peritoneum are considered as the fixed organ. So this is the one structure which is having the peritoneal fold, and it is direct. That's why it is in direct contact with the anterior abdominal wall. It is more towards the anterior abdominal wall. Regarding its external feature, we know that the large intestine must have the three types of different silent features, or the three silent features. They are the tinea coli, the hostration or the circulation, and the appendices epipulae. So these three structures make the large intestine different from the small intestine and the other part of the GIT. So it also have got the tinea coli. So tinea coli, this you can see that this is the tinea coli of the cecum. This is the tinea coli of the cecum. You could see the hostration over there. We could see the hostration. Why we are getting the hostration? Because of the length of the tinea coli. Length is much shorter than the length of the inner circular layer. That's why we get this sort of hostration. So we are getting the circulation or the hostration over here. So they are all the hostration, the circulation. This is the silent feature of the small intestine, and this is due to the short length of the tinea coli than the larger length or the greater length of the circular muscle. Besides that, the third silent feature is this appendix epipulae. We could see over here. And these are nothing but this is situated in the visceral peritoneal layer, and inside it we have got, it contains the fat and the fat only. So it has got the fat inside it. So it contains the fat. It is situated in the visceral peritoneal layer. This is the appendix epipulae, and they are the small bag of the visceral peritoneum fitted with the attached to the tinea of the large intestine, and it is attached to the tinea of the large intestine. Now coming to the development of the cecum. So cecum developed from the cecal bud. The cecal, what is cecal bud? We could see in the primitive stage of our the development, we have got the foregut, midgut, and the hindgut. We are getting the foregut, this is the midgut, and this is the hindgut. And so we have got the artery over here. We have got the artery over here. This artery, celiac trunk, superior mesenteric artery for the midgut, and we have got the inferior mesenteric artery for the hindgut. We have got the superior mesenteric artery for the midgut and inferior mesenteric artery for the hindgut, and of course we have got the celiac trunk for the foregut. Now this artery, this is the superior mesenteric artery, divides the midgut into pre-arterial, arterial, and post-arterial segment. Divides into the pre-arterial and post-arterial segment. It's the pre one, the pre, and it is post. Divides into the pre-arterial and post-arterial segment. And this post-arterial segment is known as, this is known as the cecal bud. This post-arterial segment, this is known as the cecal bud. This is known as the cecal bud. And the proximal part of the cecal bud, this proximal part, this forms the cecum, and the distal part forms the appendix. This forms the appendix. So, arising from the cecal bud, the post-arterial segment of the primitive intestinal loop is called known as the cecal bud, and the cecal bud dilates to form the cecum, and the distal part remain narrow and form the vermiform appendix. At birth, the cecum is conical. At birth, the cecum will be conical like this. It will be conical, and at the bottom we will get the appendix, and at the bottom attached to the base. So at the base we will get the appendix. So at the birth it will be conical one. So these are the different types of the cecum. So this is the fetal type. This is the fetal type. And we could see the appendix over here. This is the tinea coli. This is the tinea coli. This is 2%, only 2%. With the development of the cecum is having, it divides into two circulations. One is the right, other is the left. There will be two sacules that grow faster. And in the conical type, the appendix is attached to the base, and cecum is conical over here. Cecum is conical over here. In the infantile type or the quadrate type, it is 3%, it is 2%, it is 2%, it is 3%. Right and left sacules, the right and left sacules, this right sacules and the left sacules, both are having the same dimension, and we have got the cecum at the appendix at the bottom. Now in the next, we have got this one, this lower end, is having the same side at the lower end again. Now we see the changes. The right side grow more than the left side. The right side grow more than the left side, and the cecum comes, the appendix comes just 2 centimeter below the ileocecal junction. Just 2 centimeter below the ileocecal junction. And see the marking of the tinea coli, which just end where the appendix start, it ends over here. And finally, and this is the maximum type, this is the normal type, and this is the 80%. It is about 80 to 90%. 80 to 90% cases, we see this sort of ampullary type or the normal type. Ampullary type or the normal type, we see this type of the cecum and the arrangement of the appendix. And the next is the exaggerated type. This is the 4.5%. The right side grow more and much more than the left side, or the left is either rudimentary or absent, by which the appendix grow, the development of appendix is just below the ileocecal junction. So it will be just below this 2 centimeter length, the 2 centimeter distance between the cecum, the ileocecal junction, and the appendix. This get omitted over here, and the appendix will come just below the ileocecal junction. Now, visceral relation, which is very important. What we have seen just now, that we have seen that the psoas and the iliacus is situated. It is the cecum is situated above the psoas and the iliacus. So definitely the iliopsoas will be posterior. But what is important over here that we have to write the right, because the cecum normally is situated on the right side. So we have to write right, right, and right. Always, whenever we write any structure, we will have to write right. RIGST, right. Now the vessels, the testicular and the ovarian vessels, nerve genitofemoral, femoral, and the lateral cutaneous nerve of thigh, and of course appendix when it will be in the retrocecal recess. When appendix will be in the retrocecal recess, then it will be the posterior relation, from the posterior relation. Now there are structures which are having more breadth than the length. The diameter is more than its length. Diameter is more. So in that series, we have seen the cecum. Next will be the prostate, the pituitary gland, isthmus of thyroid gland, celiac trunk, and the pons are these structures where we will get more diameter than the length. Now the visceral relation which we have just seen, that the right psoas muscle, right iliacus muscle, the right genitofemoral nerve, right femoral nerve, right lateral cutaneous nerve of thigh, right gonadal vessels, right external iliac artery, and appendix in the retrocecal junctions will be the posterior relation. This will be the posterior relation of the cecum. So everywhere you have to write right, and right, because it is situated in the right iliac fossa. So we could see over here, this is the psoas muscle, this is the psoas major muscle, this one is the psoas major muscle coming over here. This one is the iliacus muscle. These are the iliacus muscles. Then we have got the genitofemoral nerve over here. We have got the femoral nerve over here. Then the gonadal vessels over here. This is the gonadal vessels. Then of course the lateral cutaneous nerve of thigh. Over here. And we have got external iliac artery. They are all forming the posterior relation of the cecum, and we have got the cecum over here. We have got the cecum right over here. We have got the cecum over here. So this is the cecum. Is just above all this structure. So of course, definitely all those structures which we have just enumerated will form the bed of the cecum or the posterior structure of the cecum. Regarding the anteriorly, it is very close to the anterior abdominal wall. So anterior abdominal wall and the coil of this ileum will form this anterior relation. Regarding inferiorly, we have already seen that inferiorly we have got the inguinal ligament. So we have got the inguinal ligament over here. So this inguinal ligament will form its inferior relation, and superiorly it will be continuous with the ascending colon. It will be continuous with the ascending colon, and so on and so on. So these are the relations of the cecum. Now coming to the peritoneal fold, which is a very important one. One is the superior ileocecal fold, and another is the inferior ileocecal fold. And third one is the cecal fold. It's only cecal fold. So this is the cecal fold. This is the cecal fold. This is the mesentery of the cecum, by virtue of which it is more closer to the anterior abdominal wall. So it extends from the posterior surface of the cecum, to the posterior abdominal wall. It will go to the posterior abdominal wall, and the posterior, the retrocecal recess will be lie, since it is cecal fold, so retrocecal will lie beneath it. So we will find the posterior ileocecal or the retrocecal recess lie inframedial to the cecal fold. Now coming to the superior and inferior ileocecal fold. The superior ileocecal fold is coming from this one is the ileum. We have got the ileum over here. This fold is coming from the upper aspect of the connect the cecum with the terminal part of the ileum. This is the beginning of the ileum. So it connects the beginning of the terminal part of the ileum, mesentery, and the posterior abdominal wall. It will connect it will go to the posterior abdominal wall and it will connect this cecum with the ileum, and of course it will connect it to the mesentery also. And this contains, this is the vascular one, this is also known as the vascular fold, as this contains the artery. This contains the artery, and that artery is the anterior cecal artery. It contains the anterior cecal artery. So this fold is also known as the vascular fold. This fold is also known as the vascular fold. Now we have got the inferior ileocecal fold. This is also known as the bloodless fold of the Treves. It extends from the anterior aspect of the terminal part of the ileum. Now, superior one was at the termination of the ileum, which was the anterior, the upper end of the cecum. Now we have got the inferior, which is more anterior. We will part this is tube like this. So we have got the superior this one. We have got the inferior this one. So superiorly and this now we have got the inferiorly. So it will come from the anterior inferior aspect of the terminal part of the ileum and to the cecum or the appendix, and it will travel towards the cecum or the appendix. It will travel like this to the cecum and the appendix. This is bloodless, and then of course this recess will be lie just behind the fold. So now we have got a superior ileocecal recess. This is formed by the vascular fold. Of course, this is the vascular fold, or the superior ileocecal fold is known as the vascular fold, and it lies between the ileum and the ascending colon. Here we have got the superior ileocecal recess. Then the inferior retrocecal recess will lie behind the inferior ileocecal fold, and the retrocecal recess, this will lie behind the cecal fold. This will lie behind the cecal fold. It often contains the appendix. It will often contain the appendix in the retrocecal fold. Now coming to the blood supply. The blood supply of the cecum is coming from the superior mesenteric artery, and the superior mesenteric artery divides into the superior division of the ileocholic artery and the inferior division of the ileocholic artery. Now the ileocholic artery again divide into the anterior division and the posterior division, and the anterior division and the posterior division. One is the appendicular artery, which we will get later on. So it has got the anterior cecal artery and the posterior cecal artery, and this anterior cecal artery and the posterior cecal artery, which is nothing but the branch of the inferior division of the ileocecal artery, which is a branch of the superior mesenteric artery, will supply the cecum. Regarding the venous drainage, of course, they will open into the superior mesenteric vein. The artery follows the vein follows the artery. So vein will ultimately, since the artery is ultimate branch of superior mesenteric artery, so vein will ultimately go to the superior mesenteric vein. Regarding the lymphatics, this will drain into the superior mesenteric group of the pre-aortic lymph node. Regarding innervation, we know that this is a derivative of the midgut part of the large intestine. So midgut part of the large intestine is having the sympathetic and the parasympathetic nerve supply. Regarding the sympathetic, this comes from the T11 to L1, and parasympathetic comes from the vagus nerve. The parasympathetic comes from the vagus nerve. So this is any structure which is derived from the midgut will have this sort of arrangement only. Now we have got the two recesses. One is the ileocecal recess, other one is the appendicular recess. So ileocecal recess is a projecting terminal end of the ileum into the cecum. It will project into the cecum and is situated in the posteromedial wall of the cecum at the junction between the ascending colon and the cecum. Ascending colon and the cecum. At that junction, we will have the opening of the ileum inside that. Now, this measures 2.5 centimeter transversely, and this orifice is guarded by the ileocecal valve. So, as the name suggests, one is ileum, other is cecum. So, the valve will be known as the ileocecal valve, and it has got upper lip and the lower lip. This valve, you could see over here, it has got an upper lip and the lower lip. Upper lip is more or less horizontal, and the lower lip is concave, and the margin is known as the frenulum. This is the left frenulum, and it has the right frenulum. It has got two frenulum. So the lower lip of the valve, the upper lip of the valve, and two frenulum of the valve. It has the lower lip which is concave, upper lip is horizontal, and the meeting point of the two lip on the right side and the left side creates the frenulum. So we have got the right frenulum and the left frenulum. Now again we have got the appendicular appendix also open over here. This is a small circular fold situated about 2 centimeters below the ileocecal orifice on the posterior medial wall. Again, it is also the posterior medial wall. This valve is known as the valve of Gerlach. Valve of Gerlach. This is an indistinct semicircular muscular fold. This is the indistinct semicircular muscular fold, and this is known as the valve of the Gerlach. It is situated 2 centimeters below the ileocecal valve. Number one, it is situated 2 centimeters below the ileocecal valve, and it is also situated in the posteromedial wall. Now the ileocecal papilla show muscular thickening. Ileocecal papilla will show the muscular thickening in the form of the intrinsic anatomical sphincter. The role of the valve is, since there is a valve over here, so it must have some role, and the role is that closure of this orifice prevents the distension. Whenever there is required, then this orifice will be closed and the structure will not pass from the colon to the ileum. Now regarding the clinical anatomy, abnormal position, normally what we have seen, the cecum is situated in the right iliac fossa, above the iliopsoas, above the genitofemoral nerve, the femoral nerve, lateral thigh, gonadal vessels, external iliac artery. So it is situated just above that. One, everywhere we have seen right, but abnormally the cecum could be situated in the left iliac fossa, in umbilical region also, subhepatic, right lumbar region, and pouches of Douglas also. There we could get the abnormal position of the cecum due to faulty rotation of the midgut. Midgut rotation will be hampered, or there will be some sort of problem with the rotation of the midgut. We could get this sort of abnormal position of the cecum. Now the inflammation will be known as cystitis and or the typhlitis. The interstitial tuberculosis or the ileocecal tuberculosis and carcinoma may involve the cecum. So this is all about the cecum. In the next class, we will take the appendix.